Good evening, everyone. My name is Stephen Curley, and I am the chair this year of the Solo Small Firm and General Practice Division of the American Bar Association. We're here to continue what I hope has become a confirmed tradition within our division, the Activate Diversity series. This is the sophomore year of the series. It was initiated last year under the leadership of our immediate past chair, Elfrida Coward, and the challenges of continuing that success have begun to be met with tonight's program. We're going to be learning more about access to healthcare in minority and disabled communities, but more importantly, I hope you're inspired to assist this division in advancing this issue, not only within the American Bar Association, but within the profession and within society as a whole. I'd like to, first of all, thank the co-sponsors we have for tonight's program, the ABA Commission on Disability Rights and the ABA Health Law Section, who have helped bring what I believe is a very prominent panel for your consumption tonight. I also would like to thank our sponsors in the division, Thomson Reuters, our premier sponsor, ABA Retirement Funds, and TABS 3. The important sponsorship of these partners make sure that this series gets presented to you in the most convenient and, in fact, in the most complimentary fashion. This issue perhaps does not immediately present itself to those of us who have become interested in the diversity and inclusion area. However, without healthcare and without the consideration of healthcare as a human right, we do not have the ability to forward the other issues that Dee and I bring to the table. We have experienced panelists before us. We have an engaged and wonderful set of leaders to lead us in this discussion tonight. And the best thing I can do is to make sure that you get to take advantage of the program as quickly as possible. And with that, I'd like to turn things over to our chair of our diversity board, Chisa Putman. Chisa?
Thank you, Steve. Again, I'm Chisa Putman, and thank you, Steve, for that wonderful welcome. I am the diversity board chair this year, and I am enjoying the privilege of serving. So I would like to thank each of you for joining our Activate Diversity, Access to Healthcare, Minority and Disabled Communities. This program is one of 4 planned programs for the GP Solo Diversity Board's ongoing Activate Diversity series. The purpose of this program is to bring light to disparities in minority and disabled communities as it relates to healthcare. As lawyers, we tend to take for granted our knowledge as well as other things that are simple for us. Everyone does not share the same wealth of knowledge and understanding that we possess. So it's important that we recognize those differences and be willing to assist others. People need help completing and filling out forms, and others may need assistance with legal documents but do not understand what they actually need to use. These are disparities that are present and need to be acknowledged and addressed. Our wonderful panelists will discuss these issues among others. Our call to action to you is to get involved. We're asking each call participant to make a commitment to pledge help to others. It doesn't have to be in the medical area. It can be in any area. We just ask that you help others. There will be a survey posted in the chat during the program, and we're asking you to make a commitment by completing the survey that you will help others. The survey is pre-populated, but you can also add in your own activities if you wish. In 1 year, we will follow up to see if you fulfilled your commitment, and we will recognize you for your efforts. We're also continuing our Lead and Activate video set statements. So we're asking you to click on the link for more information that's also included in the chat. In addition to helping others in the legal community, the Diversity Board, in partnership with the Pro Bono Committee, is continuing our efforts to assist Maupin Elementary School in Louisville, Kentucky. If you're not familiar with Maupin Elementary, it's one of the lowest performing schools in the country. We're asking you to click on the link and donate basic school supply items for the students. There's also an option to donate healthy snacks. Now, something very important about clicking on this link, When you click on the link and you donate the items, you want to be sure to change the delivery address to the elementary school as opposed to your address, so that the items will be delivered to the school and not to you. So again, I would like to thank you for attending our program this evening, and we're looking forward to a great program. Thank you again.
Thank you, Chisa. Good evening, everyone. My name is Daniel Tann, and I will be the moderator / host for this evening. I'd like to first introduce our panelists for this evening and thank you all for attending and participating. First, I'd like to introduce Veronica Hill-Milbourne. She is the president and CEO of Spectrum Health Services, Inc., which is a federally qualified health center in Philadelphia, Pennsylvania, serving the community for more than 55 years. Ms. Hill-Milbourne is a graduate of Villanova University's College of Nursing. She holds a master's degree in health education from St. Joseph's University and a Juris Doctorate from Temple University College of Law. As a registered nurse for more than 35 years, she has devoted her career to developing and leading home and community-based programs and services. She is passionate about community service and has been an advocate for health, equality, and social justice in traditionally underserved communities of color. Welcome, Veronica.
Thank you.
Next, we have Elizabeth Pendo, who is a Joseph J. Simeone Professor of Law at St. Louis University School of Law and a member of the Center for Health Studies and the William C. Weffel Center for Employment Law. Professor Pendo's research focuses on impact of healthcare and non-discrimination laws on outcomes and experiences of people with disabilities or chronic illnesses in order to design legal and policy solutions that promote health equity and equal opportunities in our healthcare systems, workplaces, and communities. She has published more than 40 law review articles, books, and other publications on issues in disability law and theory, health law and policy, bioethics, and is one of the authors of a leading case book, Health Law, Cases, Materials, and Problems, 8th edition. Professor Pendo is a member of the State Bar of California and New York. She is an elected member of the American Law Institute and a fellow of the American Bar Association and a past chair of the Association of American Law Schools section on law, medicine, and healthcare, and served on the ABA Commission on Disability Rights. Welcome, Professor Pendo. Last but certainly not least, we have with us Mr. Malik Bahar, who is the Director of Operations at Virtua's Access Center and Chair for Virtua's Health's second largest colleague community. With a passion for people, Malik leads an omni-channel customer access center that supports Southern New Jersey with more than 2.3 million patient interactions annually. With a focus on human experience, Virtua's Access Center is an industry leader in quality assurance metrics, employee retention, and engagement. Malik is a firm believer in the power of authentic leadership to foster positive professional culture to drive a return on investment via consumer experience. As a speaker on culture and innovative solutions for patient access, Malik has become a trusted leader in the healthcare and customer service industries. Welcome, Malik.
Good evening.
So to get started this evening, I want to start with a little quote that's been out there for a while. And it says that in the United States, racial and ethnic minority populations face tremendous health disparities due to factors like racism and discrimination. And I think when you look at that, it makes you wonder about the whole spectrum of what we're talking about tonight. And I want to start with Malik with a question in terms of how do you, as the director of an access center, deal with racial disparities when calls come in?
That's a great question, Dan. First and foremost, one of the ways we've addressed it is to have an incredibly diverse team and to work very hard to create an equitable environment. So if you take a look at our leadership, so we have over 200 colleagues in our department, and we are one of the most diverse departments within our organization. And that's all the way up into our leadership structure. We have about 10 colleagues over the age of 70, and then we also have colleagues who are 21 and 22 years old. So it really runs the gambit. And one of the ways that you can really address issues such as any type of ism, any type of discrimination, is to make sure that you have representation in the room. So that's something that, regarding inclusion, diversity, and equity, our organization works very hard to work on. But specifically within our department, it's always been a focus to make sure that, stories and experiences are represented in the room. Because what we've come to find over time is that when you have colleagues who make up different backgrounds, it increases that education, and there's a sense of understanding that we're all sharing a human experience. And then it, to some extent, lessens or decreases the instances of any form of racism or discrimination. And then the last thing I'll say before I turf it to the rest of the panel would be that when it comes to issues such as this, the number one thing that we can always keep in mind is that it's very important that the team feels supported through times where discrimination is present. We are partnering with our HR colleagues. It's incredibly prevalent that we do screen for and really find the best possible people. But then when you have those team members in that environment and they encounter something like that, you let them know that even though we're in a corporate environment and the customer's always right, that we will support you through this. This is not something that you need to be subjected to. We will continue to work on this together.
Thank you. Now, Veronica, you work in a little different environment. Why don't you explain a little bit about what Spectrum is?
Sure, Dan, and I'm so honored to be here this evening. So Spectrum is a federally qualified health service. We are one of 14,000 across the country. There are 3,000 federally qualified health centers in Pennsylvania. And as a federally qualified health center under the authorization of the Health Resources Services Administration, we're required to provide an array of services. I often tell people that at Spectrum, you can get everything that you would need from birth to grave. We offer primary healthcare services, adult and pediatric, OBGYN, dental, behavioral health, podiatry, nutrition, and we also have a pharmacy benefit program where our patients can receive their medications at a fraction of the cost. And the beautiful thing about being a federally qualified health center is that we never turn a patient away because of their inability to pay. Many of our patients fall well below the federal poverty lines, and we work with those patients. Some people think that just by virtue of being a federally qualified health center, that means you're a free clinic or that the care is subpar. Quite the contrary. Our facilities, and we have 3 currently, servicing West Philadelphia, North Philadelphia, South Philadelphia, and we're in the process of opening another health center in 2022 in the Northeast. Our facilities are beautiful, and our providers come from some of the best institutions across the country. They could work anywhere, but they chose to work at Spectrum. And why is that? I say that the providers that we have are physicians, our nurse practitioners, our social workers, and the array of staff are working at a federally qualified health center because they have community and patient care as part of their DNA. They really do care. Many of them are from the communities from which we serve. In fact, I grew up in West Philadelphia, and received all of my care at the local community health center. So it's personal for me, working for Spectrum. I'm very proud of the work that we do. And, you know, we have a board that is composed of 51% patients. That is a federal mandate. And that's important because that helps us to understand the needs of our community. It keeps us grounded. And in fact, last year, our board made a conscious decision to change our mission statement and to use the words of addressing the health inequities in the communities that we serve, and to be a leader amongst the federally qualified health services community. And we're very intentional about the work that we do. I'm sorry if I got a little long-winded, but
okay.
you know, you could tell I'm passionate about this.
That's okay. Now, within that mission and your passion, how has that intertwined with patients with disabilities? Because the part of this forum is dealing with disabilities and minorities.
Right. So we're very intentional about how we reach out to the patients that we serve. And we've been viewed over 55 years as a trusted partner. So I think it's important that we understand, where do our patients get their information, and to be present and visible out in the community so that people trust us. And because our providers look like the people we serve, there's that trust and that respect. We utilize a number of social media forums to communicate with our patients. And people see us out in the community. We have something that we refer to as Spectrum Without Walls. So wherever there's a need, that's where we are. I think about March of 2020, when COVID hit. We did not delay. We set up tents outside of our health centers, and we've had those tents out there ever since. And when the vaccine, the COVID vaccine became available, we did not delay. We started holding campaigns immediately, and we continue to do that. So we service everyone. Again, Black and Brown communities, underserved communities, disability communities. Everyone is welcome and treated with dignity and respect in our health centers.
That's wonderful. Now, Professor Pendo, I know you've done research and worked within this realm. Can you give us some of the challenges that you've come across in your research with the disability community having access or lack thereof?
Yes, thank you very much. And it's an honor to be included tonight. I think where I start is that 1 in 4 people in this country have some kind of disability. That's 67 million people. And we can think about disability as a continuum or something that everyone will deal with at some point in their life. But as we've already heard, although disability impacts every other demographic group, it doesn't impact them all equally. And I think to really achieve health equity for people with disabilities or any group, we have to acknowledge intersectionality, and that these inequities can be compounded when disability intersects with race or ethnicity, gender, poverty, or another characteristic. So we know that adults with disabilities are more likely to be older, they're more likely to be women, they're more likely to be Latinx, have less high school education and a lower income, and be unemployed. So we're really dealing with these overlapping disadvantages that do impact access to care. We know in terms of the social determinants of health that despite the incredible diversity within the group, people with disabilities, they have lower levels of education, lower rates of employment, higher rates of poverty and food insecurity, more problems finding safe, affordable, and accessible housing, and also transportation. And they're much more likely to be a victim of violent crime. So that sort of sets the table of the disadvantages people would be experiencing. And then in terms of health and healthcare in particular, on average, and of course this varies depending on type of disability and other types of identities, but people with disabilities have much higher rates of chronic conditions, including chronic conditions that would make one more vulnerable to COVID. They report being more likely to go without needed care. They have lower rates of preventative care. including high-value cancer screenings like mammography and prostate cancer. They have lower rates of care related to sexuality and reproduction. That's especially true for women with disabilities in prenatal care. And they have lower quality prenatal care. Women with disabilities will report that they were never weighed during their entire pregnancy because the institution did not have an accessible scale. And folks have researched, including me, have researched what are the barriers: health insurance, transportation, communication barriers, lack of accommodations. Sometimes healthcare spaces are physically inaccessible for people who use wheelchairs. But probably the biggest barrier is stereotypes, misconceptions, and false beliefs about disability.
Okay, thank you. Now, COVID-19 brought out some of the technological advancements. We learned of Dr. Teledoc. And for a person who has limited education and may have some disabilities, that presented some difficulties. And I want to throw it out to all three of you, and I'll go to Veronica first. How did your organization deal with the Teledoc situation?
Well, actually, telehealth, telemedicine turned out to be a tremendous benefit for the patients that we serve. Many of the insurers waived the copay for patients, so that removed a barrier. You know, I think about the single mom who may have 2 or 3 children and is needing to make the decision about whether to seek primary care for herself or to put food on the table. Now she doesn't have to make that decision. She doesn't need to worry about bringing the 3 children out of her home into the health center. She can access care for herself and for her children from the comfort of her own home. And how we approached the pivot to a telehealth model is that we used every resource in our toolbox to reach out to our patients to let them know that there's a new way that care will be delivered to them. You know, not many of our patients don't have access to a computer. So right now, many of our insurance companies are allowing a simple audio telephone telehealth visit, and it's working well. We've seen our quality measures soar. Patients really have responded well to telehealth. It's my prayer that it never goes away because it works. We know that it works. Now, there are some instances where patients certainly need to come into the health center. The physician needs to physically see them, lay hands on them. But for the most part, it's worked. I would say probably about 40% of what we're doing right now is still telehealth. We're using a hybrid model.
Malik or Elizabeth, you want to comment on the telehealth, teledoc situation?
I'll jump in and really just echo a lot of Veronica's sentiments. Our organization had a small footprint with our telemedicine offerings, but once COVID really hit, our digital transformation office and our medical group really came together to accelerate the offerings to the community. And to Veronica's point, I hope it never goes away as well. Truly, telehealth, most members of even underserved communities have an access to a smart device of some form and some level of access to Wi-Fi. So because of that, we saw encounters that may have been no-shows due to transportation issues or other issues, financial. We saw no-shows decrease. And we also saw the amount of visits really kind of expand within families, because now, you know, mothers and caregivers who might have been at home, as Veronica mentioned, with their children, no longer had to make a decision which one got to come from school and go to the appointment. And then additionally, we also saw quite a few families, you know, quite a few parents, and I'm sure some of us on this call today went through this as well, become the teachers ourselves, you know, because your children were at home. So it just provided greater access overall. And the organization really pushed to that. And we saw our encounters explode more than 400% across the organization. And it's really been something that's been beneficial, I would say.
Elizabeth?
Yeah, I would add, as you know, as is obvious from the wonderful answers we've already heard, I think telehealth and the experience with telehealth is a wonderful example of what we in the disability rights community call the curb cut effect. And that means that something that increases access for people with disabilities, like telehealth, that eliminates the transportation barrier, but it also helps lots and lots of other people. So when we think about, these access issues, we're never just providing access for one group. We're actually increasing opportunities in ways that we may not have even anticipated. Parents, people in rural areas, people with transportation issues can all tremendously and have tremendously benefited from telehealth. And I also hope that we make those changes permanent and that it stays a feature of healthcare systems.
Wonderful. So in our profession as attorneys, and I don't practice in this realm, but there is a belief out there that oftentimes physicians will encounter a minority person or a disabled person and make the assumption that their insurance will not cover certain types of tests or exams, and therefore they do not order them, to the detriment of the patient. Have either of you come across research or instances where that has occurred?
Absolutely. We've seen it at Spectrum, but I think that's one of the reasons why coming to a federally qualified health center is a wonderful option for underserved communities, because our patients don't have to feel marginalized. Our providers come from the communities that we serve, and they're very acutely aware of what's needed and where there are those disparities. And one of the benefits of getting care at a federally qualified health center is that many of us have financial counselors. So we will work with a patient to try to get them qualified for medical assistance. And again, if they don't qualify for medical assistance, we will work on developing a sliding fee schedule. We have patients that pay as little as $5 a month. Again, whatever that patient needs, we're not going to turn them away.
Anybody else want to comment on that topic?
So the only thing I would add to that would be that from the perspective of virtual health, when you think about those disparities, obviously the numbers state that those things do happen. But what we've come to find is that, as Veronica mentioned, there are quite a few programs that we have in place, pretty robust offering in regards to how do we make sure that those things are being addressed. So our organization has, clinically licensed social workers that work directly with the patients to extend that level of care and really be that advocate and that voice. Additionally, community-based health managers. We have patient experience navigators, which are located in our EDs, so that when you find a patient who may come to the ED and is using an ED as a primary care because they don't have regular access to care, those patient experience navigators will get that patient then set up with a primary care doctor. So, while we do know that in healthcare, those things do occur, it's really about, from my perspective, what are the organizations do to address that head on and really put processes in place to reduce the impact of that.
Excellent. Now, looking broad scope at healthcare, we all know that there in this country, there's a large segment of people who do not speak English. And that has been an inhibitor. And I guess the access piece there is, from Malik, from an access center standpoint, what happens if a non-English speaking person calls your access center and the phone is answered and they don't understand hers?
Understood. So current state, we do have access, as many access centers do, contact centers do, we do have access to a language line. So while we do have bilingual navigators on our team and bilingual clinicians and clinicians who speaks all types of languages, and we are able to partner potential patients with clinicians who may speak their specific language. Within our customer relationship management system, we do have that information so that if we have someone who has a specific language, we can match that patient to that provider. But in real time, it does occur and it can be a gap, but we have access to a language line where we would, let the patient know with very basic translation that we will be right with them. We access an interpreter, and in real time, the interpreter plays the arbiter between ourselves and the patient. And one of the things that we have been discussing internally as we look to 2022 is to really develop a team that specifically in-house can deal with any type of common language occurrence that our team cannot current state. So something we're looking forward to.
And Veronica, how do you deal with that at Spectrum?
Similar to Malik, we also have access to language line platforms. We also employ staff that speak multiple languages. And in fact, as we prepare for our Northeast Health Center, which is going to be servicing a very diverse community, we have budgeted translators because we really believe that it's important in terms of the patient experience to have someone that they can communicate with from the front door upon entry to the time that they leave. So we want to make sure that everyone that walks through our door is provided with what we refer to as a world-class experience.
Now, Elizabeth, I know
Yeah,
you're going to jump in there.
Very thoughtful responses and practices and policies put in place to make sure that patients are cared for. The same goes for people with disabilities, right? American Sign Language is just another language. And of course, people with disabilities, if you have a cognitive or intellectual disability, it may have less to do with the language that you speak, but more about the way in which you're communicated with. And healthcare systems have made huge strides toward ensuring that kind of effective communication for people with disabilities. I think where we see the real challenges is in an emergency situation when someone presents at the emergency department. Based on the nature of their injury or consciousness, it may not be clear what language is best to communicate with them. But again, you work through those issues as they come.
Now that you mentioned that, Elizabeth, dealing with the hearing and visually impaired individuals, what has your research shown in terms of their limitations on access to healthcare?
Well, the Americans with Disabilities Act and also the earlier Rehabilitation Act require effective communication. So most healthcare systems do have methods of communicating with people who are hard of hearing or have vision impairments or both. And again, in a non-emergency situation, you could communicate that need and your physician or institution could be prepared to be able to communicate with you. But it can become a serious issue in an emergency situation. And of course, COVID has made that worse because people who rely on lip reading or other kind of haptic clues by facial expressions cannot access those facial expressions because everyone's wearing masks. It's also been a significant challenge for people who are hard of hearing, both patients and providers. To have to understand spoken language through a mask. So that's really been an ongoing challenge.
Any solutions?
Well, there has been clear masks and lots of folks are using clear masks. Ideally, if folks have been vaccinated and received the booster, you might be able to communicate without a mask, and certainly over telehealth, you can communicate without a mask, and it can be much easier to understand and interpret what people are saying.
Excellent. Now, part of the issue with the access is that it's not something that just happened overnight, that it's been systemic, that it's occurred over decades, and that it's sort of ingrained in certain communities. And I guess the question at this point is, what can we do as attorneys to sort of help alleviate the problem from your perspectives? And I'll start with you, Veronica, from where you sit at Spectrum.
So I think just having attorneys aware that federally qualified health services and centers are a plausible option for their clients. And it's important that all people, not just those who are traditionally underserved or at risk, have access to good primary care. We don't want to introduce people to a primary care provider during a crisis, but during a time when we can focus on getting to know the individual, having a thoughtful plan of health and wellness, such that if there is a critical urgent situation, we're not scrambling to try and understand that patient's healthcare needs, their family history, because there already is an existing relationship. And in that relationship, there is a degree of trust that has been established, so that when a care strategy is proposed, the patient is much more likely to adhere to a treatment plan if they have a relationship with a provider that they trust. So from our legal community, keep this as a tool in your toolbox that community health centers have been servicing at-risk communities forever. And we provide a great solution for those clients that are in need.
Elizabeth, do you have any recommendations for the attorneys that are listening and watching tonight?
Yeah, I would say for attorneys, you know, it's interesting. Law professors, when they approach a problem, usually say there should be a certain type of law. In my area, there is a law, you know, that's actually has very strong, the ADA has very strong guarantees for equality and access, but it's often not followed. And that seems to be especially an issue in healthcare. So I think advocating for strengthening and enforcing the ADA and other civil rights laws, and not just in terms of litigation, but education is really important. What are those protections? And patients need to know that, and providers need to know that. I think acknowledging painful histories. The healthcare system has racism built into it and also ableism. So acknowledging those past abuses is really important, and to show patience and humility in building and earning that trust is extremely important. Representation is part of that. As a researcher, I think data collection and research is also important, because we need to close that knowledge gap and give providers the information that they need to be able to provide appropriate care to all different kinds of patients.
Great. Now, Malik, I don't know if you have any points that you want to give to the attorneys.
Well, those who know me know I always have an opinion. So in preparation for this call, gave this question a lot of thought, because obviously as attorneys, it can be a bit nuanced. So I would challenge the group to approach it just from a human perspective. Really at its core, the professional aspects of it would be making sure that the things that are happening in your area within your healthcare systems that pertain to your clients are equitable. But additionally, if you wanted to take a step further and get involved, it could be to specifically address the social determinants of health. So are there rideshare programs in your community, in your neighborhood? Because a lot of times community members who are disabled or underserved don't have access to transportation to get to an appointment, whether it be emergent or preventative appointment. Is there a particular area that you may have an interaction with where it's a food desert? Our organization has quite a robust mobile grocery program, and then also mobile mammography. So really, how can you, whether you're donating your time through Big Brothers and Big Sisters, because a lot of times, or any type of virtual workshops, a lot of times what happens in those communities, because similar to Veronica, I'm also from Philadelphia and from a community that we're speaking about today. But in those communities, a lot of times people don't have access to information themselves. So if you do, as what Veronica and Elizabeth both mentioned, which is educate yourself, you can be that you can be that buffer, you can be that example, because a lot of times the members of that community have not seen someone who's been as successful as you have. You have worked very hard to do so. They may not have a plan of action. And the fact of the matter is that while we're talking about health itself, we're also talking about examples and role models and understanding. So that would be my recommendation, respectfully.
Okay, thank you. Good advice, good suggestions. Now, one of the other things that I think has been a contributing factor is maybe 20 years ago, we all had individual physicians who were in the neighborhood, and we didn't go to the great corporate structure that Malik works for. And we had, Dr. Smith, who our doctor, but was our father's doctor and our grandmother's doctor, and he knew the family. And now we don't have that structure. And do any of you feel that that lack of personalization has led to a lack of access to medical care for minorities or disabled individuals? And I'll start with Elizabeth on this one.
I think it's had both positive and negative effects. I mean, the benefit of larger structures is they can leverage knowledge across, many more interactions, and they can institute some of the healing and equitable policies and practices that we've already heard about tonight. I do think the interruption of that personal relationship with the physician does have the potential to erode trust or make care more fragmented. And part of that isn't healthcare institutions. Part of that is how we finance healthcare through insurance systems. You may have you may participate in many different systems of insurance, all of whom may have different networks. So even if it's everyone's intention to continue that relationship, the fragmented nature or the patchwork nature of how we finance healthcare can cut against that. But I think it's still that personal relationship when you go in to see a provider, and not just a provider, but everyone who works in the medical office, everyone who works in that institution. You're having individual interactions with lots of different people. And I think those are incredibly important to build trust and help people be more likely to follow through with their treatment plans. I think for people with disabilities, for people with certain kinds of insurance across race and ethnicity and gender identity and sexual orientation, it can be challenging to find a physician to build that relationship with. And I think we need to encourage and support everyone in doing that.
Thank you. Malik, do you have any thoughts on that question?
I think that it has certainly had an impact, but we're really at a crossroads in healthcare with this issue. Truth be told, if you are above a certain generational line, you certainly want that continuity of care. You want to see the provider that your parent saw, that has seen you, for quite some time. But with the millennials and younger, a lot of times they just want to go where it's, fastest and it's very transactional. They would appreciate if the person knew them, but honestly, that their top priority is their time. So we're kind of at a crossroads with healthcare in that regard. But I will always say one of the things that has made this role for me very appealing is that we have found a way to lessen the impact of kind of the corporate experience. And most of our primary care practices have been in place for quite some time, have strong foundational roots in the community. And then even in how we support those practices in those offices, we have a dedicated team who get to know the patients of that neighborhood who specifically service and support that office. And we found that that has really helped breed a certain sense of connection, so that you're not just talking to a random person in a contact center that you think is across the country. So because of that, their familiarity and that trust is incredibly important. And while I know those things exist, it's something that we work actively to combat.
Veronica, I know you have a good answer for this one.
Well, just by virtue of having all of the available services under one roof helps with the ease of access and our providers many of them have been with the organization for a long period of time and treat families through a course of time. So it gives you that old traditional sense of community. There's a trust that has been established with our providers. But to Malik's point, the newer generation is all about time and ease. So we provide that as well. And the fact that now we have telehealth as a new model of care, that responds to many demands, and it works well for us. So I'm not seeing as much of an issue as maybe, our larger health institution. Now, there is a new issue that has plagued this country, and that just is finding healthcare providers who really want to work. I know that there is a huge demand across the country for people who are willing to work in underserved areas or to work in just period. It's something that we're all struggling with. Spectrum is not unique to that plight. And we have to think about, during the initial COVID pandemic, many people left healthcare out of fear and just concerned with their own personal safety. And then you add in to the equation all of the people who lost their lives as a result of COVID. So that left a huge void that we're all trying to figure out how to address. Enormous competition across the country with people trying to steal talent and to retain their talent. And we struggle with that. I'm sure Malik deals with it as well.
And I guess that brings me to my next question. And I don't know if this is really related to access to race, but I just access in general. People have said when they call, let's say, a specialist and they want an appointment, the appointments are 4, 5, and 6 months out. And that may pose a problem to someone who's really ill, that they have to wait 4 or 5 months out. How do we address that, and what suggestions do you all have for that type of situation? I'll start with Elizabeth. What have you found for the disability community, how they react when that occurs?
That's actually a tremendous issue because providers who might have expertise in a specific kind of disability or multiple disabilities, because of course you can be experiencing more than one, are very hard to find. And they often are stretched to the limit, motivated to try to treat every possible patient that they can, but only having so many appointment slots in a day. And sometimes treating people with certain kinds of disabilities, it's a myth that it always takes longer, but sometimes it does take longer. So it may even mean seeing fewer people in a full day. So that's a real challenge. But again, I think it goes back to incentives that we create in our healthcare system. What is the reimbursement structure? Why do people feel that they need to or want to go into certain specialties and not others? And if we're serious about equity, then we need to think about how we compensate healthcare providers and how we reimburse healthcare institutions to treat people who might be more complicated or take more time or have a different form of insurance. So it becomes an individual level problem, but really the solution is a structural one.
Okay. Veronica, what are your thoughts?
I agree with what Elizabeth said, that it is a structural issue. And I don't know that we have a solution to the problem. I think we have to be very creative and share resources whenever possible. We have established a number of partnerships, community partnerships with health systems, with advocacy groups, so that we can share information and resources. But I don't know that there's one solution.
And I'm assuming, Malik, you probably bear the brunt of the frustration because they probably call into your access center very frustrated as to why they can't get in to see the doctor.
Yes, so I'm very excited to answer this question, mainly because it pays due and homage to some pretty visionary people. When my team was founded 13 years ago, our leaders started with a very basic premise and model, which was that the medical maze isn't getting any simpler. So in times such as that, you've seen your doctor, you've received a diagnosis that's less than favorable, and now you need to follow up with some form of specialist that will be booked out several months. Our team of navigators, the essence of our department is that you contact us and then we lighten that load for you. So if your situation is emergent, with all of our specialists within our network, we know that we can escalate, reach out to the office manager, and they will find a way to reduce that time from perhaps 4 weeks to 2 weeks. In some specialties, the time is reduced even greater than that. So that's a model that's been tremendously successful for us. And part of the reason why, like Veronica, I'm so passionate about the work that we do, because we truly do get a chance to help people, whereas they've reached barriers in many other on their own, and in many other cases, when they do come to us, we have established pathways in place to simplify that for them.
Wonderful. That's great to hear. And I guess I want to go to Elizabeth now. And can you tell us some success stories that you've been involved in relating to access to healthcare?
Sure. There's been a number of collaborations with different healthcare systems, starting with the Kaiser Permanente healthcare system in California in the early 2000s around increasing access for people with disabilities. And they started with sort of a smaller or more specific issue, and that was people with disabilities were going into facilities to receive care, in particular, people with mobility disabilities, and the examination tables and chairs and the scales and the imaging equipment weren't designed to be usable by people who weren't able to stand on their own or get or stay on a table on their own. So if you're going in for an examination and you can't safely and securely get on the table, you have a problem immediately. But in this interaction with Kaiser Permanente, it blossomed into something, much larger. Physical access generally, communication barriers, training and education for providers. The ultimate agreement went far beyond even what the law would require. And really to the benefit of so many different patients with disabilities, and also the providers, many of whom said, we don't have training in caring for patients with disabilities, and we'd actually like to have that training, because if any provider, given the number of people who have disabilities and the aging population, you should expect to see many, many patients with all different kinds of disabilities. And if you aren't, there's an access barrier to your practice. So learning from different specialties. A lot of the access problems, right, were solved by orthopedic practices who are very used to seeing people with all sorts of temporary or permanent impairments. So I think there's been a lot of these collaborations with healthcare systems that have been cooperative and very, very beneficial.
That's great. Malik, can you give us a success story from your point of view relating to access?
Certainly. Elizabeth made a very good point earlier about a lot of issues being structural. So when I think about access, I think about the role that our team plays. Historically, contact centers you would contact, you pick up a phone, you call a number, someone answers, they tell you what's available, and that's it. With what makes our team particularly special, and within our organization being given the latitude to create a team to operate like this, is that we're really consumer advocates. And what we really are empowered to do is, if someone calls us, a lot of times, I'm sure both Veronica and Elizabeth are familiar with this, a lot of people just need to be heard because they had a negative experience because no one was available to help. Although we are a contact center, if someone needs to vent for 25 minutes before we get to an appointment, we don't rush our team off the phone. That's incredibly rare in our industry, and it's something that we're very proud of. Additionally, we're trending at over 3 million patient interactions this year, and a record number of appointments scheduled. And one thing I would mention as well is that our model is a bit different in a few other ways, in that if the service that is needed is not something that falls within our network, we will call our direct competitor, because the goal is to really meet the patient where they are and provide them with the service that they need. This has resulted in very favorable reviews from our community. And additionally, we've been able to create a culture internally that, as mentioned before, is incredibly diverse, equitable by all accounts. But additionally, contact centers are usually are places of tremendous turnover. It's a transactional job. People get burned out. But our retention rate is 92%, and our team engagement scores are some of the highest in our organization. And the reason for that is because we tore down the previous model and built something new. So from that standpoint, given that our whole premise is to provide access, tremendously proud of the team and to have the chance to be a part of it.
Great. And Veronica, do you have a good story for us?
Well, of course, you know I have several stories, but I'd like to talk about two stories. The consortium is a mental and behavioral substance abuse provider in the Philadelphia area. Been servicing constituents of Philadelphia for over 50 years as well. And they reached out to Spectrum because they realized that they had a large constituency of patients with HIV, AIDS, Hep C, and just in general need for good primary care. And we offered to set up a satellite site within the consortium to make it easy. Again, removing barriers. Many of the patients that they serve have to be there multiple days a week for group therapy, counseling, and just, mental health support. Why not provide primary care and dental services right there on site to make it easy? The model's been tremendously successful. Another example of success, and one that is very unique to a federally qualified health center, is the use of an integrated model of care, which brings in behavioral health supports. The last time I looked at our data, over 25% of our patients had a mental or behavioral health diagnosis. And the fact of the matter is, I know that number is low. We could be doing a better job of identifying patients who struggle with, personality disorders, depression, anxiety, because it's real, especially in the communities that we serve that have so many social impacts. And the beauty of our model is that our providers or physicians or nurse practitioners have the advantage of a behavioral health specialist at their beck and call to come in and help them to address the patient's total health needs. And that's one that I'm very, very proud of. I can't tell you, there's so many stories of how that partnership has worked to really transform people's lives and, quite frankly, save lives. People who have been suicidal, that we've been able to get in, provide support, get them the crisis, care that they needed, that really saved their lives. So those are just two examples.
Thank you. So at this point, what I'd like to do is give you all the magic wand and say to you, if you could change something about the access to healthcare, what would you change? And I'll start with Malik.
I appreciate that, Dan, given that this was the first question that I didn't have a ready-made answer off the top of my head. I don't know, that's such a profound question. I guess it would be that as healthcare continues to evolve, it really continues to meet patients where they are. I think a tremendous example of that has been the Telehealth Initiative. It removed a lot of the barriers that previously were consistent for years. Now with telehealth, people can connect with their provider even if they can't make it into the office. But a great example of what I'm speaking about by meeting people where they are is that during the COVID vaccination process, Virtua's organization partnered with several different churches within underserved community Baptist churches to hold clinics. And over 3 days in March and 3 days in April, we vaccinated over 3,000 minorities and people who had previously stated that when they called the major state-run mega site that we were also a part of, that they had some access issues. But because we came to them, not only were they able, for those who wanted to receive the vaccination, but additionally, they were also given the opportunity to schedule additional services and really become part of the network. So I would say more of that. Waving a magic wand would be kind of more of the community face-to-face impact, as much as is allowed within COVID times. But a lot of that really builds that trust and kind of extends that olive branch to our community members so that they no longer feel excluded.
That's wonderful. Elizabeth, what would your magic wand do?
Well, I think the biggest barrier for people with disabilities really is attitudes and assumptions. And changing those attitudes is really a work in progress. To really come to see disability as a demographic characteristic, as a culture, as a valuable perspective, and not simply as a negative health outcome. I think because I teach law students who are our leaders of the future, I think a lot about upstream type of solutions that revolve around education. I think increasing diversity in medical schools and other healthcare professional schools is really important. We've heard a lot about the importance of representation and also of unique knowledge and experiences of different kinds of people that we can bring into the healthcare system. I think there are also opportunities for training in disability cultural competence for all kinds of healthcare professionals. And there's actually some really exciting work and models in that area. And it's a great moment to kind of reach into that. And I think also the recognition that discrimination itself has negative health impacts. It's not something separate from individual health. It's something that cuts against health and well-being, just as other social determinants of health do. So I think really continuing to press forward on that very difficult issue of changing hearts and minds around disability and other characteristics.
Okay, thank you. Great points. And Veronica, your magic wand.
So my magic wand would be that our insurance companies look at the way they approve panels, that they make sure that the panel or network that is available to underserved communities is truly representative of the patient population that exists within that community, and that the reimbursement for organizations like Spectrum is equal as compared to some of the larger health systems. For Spectrum, being a federally qualified health center, I can't compete with the salaries that a larger health system might be able to offer. So again, I've got to rely on people who again have community in their DNA and really believe that their calling is to transform communities. In addition, I think Elizabeth is absolutely correct that there needs to be a focus on diversity, health equity, education within the healthcare community. At Spectrum, we've been very intentional about training our staff to respond to the needs of underserved communities, to offer culturally sensitive care, so that we speak the language that our patients need us to speak, that we are able to treat everyone with dignity and respect so that they feel safe when they come into our health centers. So again, my focus would be making sure that insurance companies are looking at their panel network and making sure that it's representative, and that reimbursement is appropriate for small providers like a federally qualified health center. And then that thirdly, is there a focus on making sure that the healthcare continuum is developing culturally sensitive and appropriate care options for those that we serve.
Thank you. All great suggestions. So at this point, we're going to open up for questions and answers. And I see Nicholas Lawson has his hand up. So Nicholas, you can ask your question.
Sure. Yeah. So I'm an MD and former psychiatry resident, person with a disability, and disability diversity within the health professions is something huge to me. I experienced discrimination as a psychiatry resident. One thing that's very exciting is that there's a bill. It is HR 3320 to amend Title VII of the Public Health Service Act, authorize assistance for increasing workforce diversity in the professions of physical therapy, occupational therapy, respiratory therapy, audiology, and speech language pathology for other purposes. Great bill. So it's racial, ethnic minorities, and persons with disabilities. I mean, these are groups that are really underrepresented in the medical profession. Unfortunately, we don't have a bill like this for physicians yet. This is terrific. I'm more of a negative rights than a positive rights person in general. In terms of access to care and behavioral health issues, I think me and some other folks in the disability community are concerned about trends, for example, with respect to addiction services, that we feel like the addiction advocates be learning from the history of institutionalization and deinstitutionalization of persons with serious mental illnesses. And we see the trend towards screening pregnant women in hospitals and aggressive efforts. So the trend towards institutionalization of persons with addictions is troubling. And I'd like, I'd hope that as minority and disabled communities together can be skeptical of medicalization and institutionalization and be cautious before naively diving into access to care wholeheartedly without taking into account of some of the histories of how we've been marginalized and screwed by the medical profession. That's just my 2 cents.
Thank you. Do we have any other questions, or does anybody want to respond to that statement?
I would like to respond to Nicholas because, as I mentioned, a large portion of our patients are struggling with some mental or behavioral health diagnosis. And our goal is to keep people independent in the community, living their fullest capacity. What we're finding is that there's such a shortage of mental and behavioral health professionals that can provide that mental and behavioral support. We have to create attractive means to bring people into the field so that we can have an adequate supply to help those people who are really struggling to manage their healthcare, mental and behavioral healthcare needs.
Any other questions? Just raise your hand.
There's a lot of really good work being done in this area. I think substance use disorder, certainly the history of regulation around substance use disorder, not just medical care, but also the criminal law, has been absolutely riddled by not just ableism, but racism as well. So we're starting from that kind of problem. And it's really people who are dealing with this issue are really having to struggle against multiple layers of stigma and disadvantage. I think also even in medicine, there's a lot of addiction exceptionalism. Sometimes non-evidence-based approaches to care are still put forward by institutions and certainly by the courts. And I think the point about the dangers of medicalization, it's really important, but I think there's also a balance there. People with disabilities have long said that it's not just an individual biomedical problem. It's actually an interaction with an environment that's inhospitable or built on ableist principles. But it's really both of those things. I don't think we want to go all the way to a pure social environmental model, because then it really diminishes the moral claim to healthcare when people have medical conditions that require healthcare. But you're absolutely right, because of these overlapping stigmas, people with substance use disorder are way too often not provided with the care they need and subject to discrimination in multiple areas of their lives.
Any other raised hands? Right. Seeing no raised hands, like to thank our oh, wait a minute, Amy Albright, I'm sorry. Amy?
How do you address, because of the major problem with those older adults who come in for care and sort of lose their voice in how they want to be cared for? You know, those older individuals who may have disabilities, who you know, maybe African American. You know, our regular healthcare system sort of pushes these people out, and I'll just say it, to pasture. And so, you know, how are your groups addressing the needs and the voices of those who are aging, and without being dismissive, and, you know, keeping respect and dignity and decision making?
Veronica, you want to tackle that first?
Sure. Well, I don't think that we have an issue at Spectrum. At least I'm not aware of an issue, because I think that our staff, our team, is representative of all age groups. Our case managers, I think, do a wonderful job in making sure that we are treating our patients with dignity and respect, and that the care that we provide is patient-centered. We are certified by the National Quality Assurance Committee, NCQA, as a patient-centered medical home. That means that we are certified and have demonstrated that we meet the patient's needs, and that the care is very sensitive and responsive to the goals of the individual patient. We take great pains to make sure that no one is marginalized, that everyone is treated with dignity and respect, and that their voice is actualized.
Malik?
I would echo the same of what Veronica just mentioned. Really, the way our organization is set up in regards to our mission and our vision, and really our brand promise, which is to be here for good within our community. Truthfully, for speaking from my team's perspective, and then also having the opportunity to work with leaders from across the organization, a lot of times those colleagues, those patients who, or, you know, community members who may be aging, are the ones who make up our patient, family, and advisory councils. They are the ones who are very vocal when they call and speak with our team to really kind of state, you know, express themselves. And we have a pretty, we have an organization that really focuses on transparency and understanding, but it's really about a culture of care. So truth be told, I would say as well that while nothing can be 100%, I don't believe that virtual health has that particular issue, but we are advocates in that regard, that if a patient is even experiencing that somewhere else, a lot of times they will say, hey, the reason I gave you guys a call is because I experienced this somewhere else. It's one of the things that, you know, in my role, you know, as a director, I have direct access to senior leadership and to express certain things. We have, you know, inclusion, equity, and diversity councils. And I'm also the chair of our Black and African American colleague community. So it's one of those things where when those stories, if and when those stories do come across our desk, there's a pretty strong network of leaders who take those things to heart and take instant action about that. Those members, my mother included, and many others, are the foundation of our network. So it would be incredibly disappointing to see people be pushed out. But I do know that exists, but it's something that we work actively and diligently to address.
Thank you. Elizabeth, I know you don't have an organization, but you might have an opinion.
Yeah, I always have an opinion. These are wonderful, wonderful answers and approaches. I think like so many other problems, I think the concepts and the ideas in the Americans with Disabilities Act have a lot of good work to do here. The idea of how easy is it for an older person who might have age-related impairments to make an appointment to actually get into the physical exam space? Are we sure that the good communication is happening? And that focus on individualized patient medicine and really understanding the patient goals is really an ideal way to make sure that effective communication is really there. There could be a hearing impairment that the healthcare provider isn't aware of, and that even the patient isn't fully aware of. Or other kinds of communication barriers are really important. And then thinking about those stereotypes and getting to know people as individuals is one way to break down those stereotypes. Are we making assumptions about goals or activity levels or the nature of the life of an individual who is older, or are we listening to the patient telling us what they do, who they are, what they value, and what their goals are? And I think that focus on patient-centered communication and patient-centered care will go a long way toward breaking down these stereotypes.
I have one last point. When you talked about the magic wand, I think the magic wand would work so well if we could take what Veronica, Malik, and Elizabeth are doing and relatively make sure that it became many places that are offering this kind of cultural competency and getting grants to open up places and get good talent, because I think this kind of medical model leads to much improved health, where people feel heard, where they actually will go back to get care rather than just slip through the cracks and never to be seen again, depending on how, they felt when they walked in the door. So I guess that would be my wand. Wonderful, wonderful discussion, everyone.
Thank you. See if we have any other hands up. This one. Malik, you have your hand up. Oh, I guess.
No, I was just clapping at what
Oh,
I don't know if it populated the right way, but clapping about what Amy said. I thought it was very well stated.
Great. Okay. I'm just checking one more time to see if we have any other hands up. And I don't see any. So I want to thank our excellent panelists for your time and energy, and I'm going to turn the program over to close us out with Jamie Boston, who is our Division 1 Director. Jamie.
Hello, everyone. Happy holidays. I just want to thank the panelists. You all were excellent. As a disabled veteran myself, and also the caretaker of 2 disabled parents, access is crucial. And thanks for all the knowledge that you shared. And we all can take a part. You never know when you can be hit with a disability. Those who are well able right now, you could be sick the next day and need these things that we're talking about tonight. So this is a crucial discussion. I just want to thank you all for being here, participating. I'm just going to close this out for you on behalf of our diversity director, who is Kelly Adams. Unfortunately, she had a little incident tonight, so she couldn't make it. But we just want to thank all of you all for being here. Want to wish you a happy and Merry Christmas and holiday and Hanukkah, whatever celebration you may have. We just ask you all be safe. As we all know, we're talking about disabilities. Coronavirus seems to be on the rise again, so please take care of yourselves and your families and your friends. And again, just thank you for being here. I just want to bring your attention to, this is just the first of a 4-series program that we're doing. We started this last year, Activate Diversity. I believe Chisa, our chair, might have spoken about it already, but just to let you know a little more information, our next 2 programs, or the next program rather, is scheduled for February 24th. That's going to be Activate Diversity, Racism, Vigilantism, and Mob Violence in America. So that's pretty deep. So I hope you all come, bring your friends, bring your families, and come listen to it. We're going to be doing another one, a 3rd series on CRT. That's going to be determined. So I don't have a date to give you that one yet, unfortunately, but look out for that. We'll get the information out for you. And the 4th one to close it out will likely be held during our spring conference, which will be held in Los Angeles, California. And the exact date's not set yet, but it'll be sometime during the days of April 27th to the 30th. And so I encourage all of you to please come. This is a great series. We started last year, and I'm glad we're continuing it as it goes on. I don't know if our chair, Steve Curley, has anything to say, but just want to thank him for his leadership and continuing this series for this year, as well as you can see in the chat. One last thing is to pump and celebrate our adoption of Maupin Elementary, which is a school in Louisville, Kentucky that we're supporting. We started that last year as well. Hey, we're in the giving season, so please check out the link there and help these kids achieve their goals. And maybe they can be on this panel with us one day. Again, thank you. Everybody have a good night. Merry Christmas, Happy New Year, and hope to talk to you soon.